Good evening, everyone, and welcome to our Consumer Forum on Public Fertility Care. My name's Katie Beveridge, and I'm the Operations Manager of the Public Fertility Care at the Royal Women's Hospital. I'm so excited to be here tonight talking to you about our amazing service. So thanks for registering and submitting your questions. We've developed these presentations with your questions in mind, so hopefully we're able to answer most of those for you. Next slide, please. I'd like to acknowledge the traditional custodians of the land on which each of us have dialed in from this evening. I'm speaking to you from the lands of the Wurundjeri and Bunurong people of the Kulin Nations, and I wish to pay my respect to elders past, present and emerging. I'd also like to acknowledge any First Nations people here with us this evening. So tonight we have a team of experts to speak to us on the common causes of infertility and the treatment options. I'll then come back to you to talk to you about public fertility care, the costs, eligibility and the waiting times. Then Juliana, our Nurse Unit Manager, will step us through 2 patient journeys. So I'd like to introduce to you Co-Medical Director of Public Fertility Care at the Royal Women's Hospital, Associate Professor Wan Tien Tay. Thank you, Wan.
Thank you, Katie. Good evening, everyone. So I'm going to start the webinar tonight with some important information on infertility based on a global study by the World Health Organization. Infertility is a common condition that affects many people worldwide. According to this recent data, 1 in 6 adults have experienced infertility at some point of their life. So this statistic comes from a study involving 8,500 couples. Infertility can have many different causes. This study shows that 37% of cases are related to issues with the woman, 8% of cases are related to issues with the man, 35% of cases involve both the woman and the man, 5% of cases don't have a clear cause, which shows us that there's still a lot to learn. But there's also good news. During the study, 50% of couples were able to get pregnant. So this data highlights how important it is to recognize infertility as a health issue that affects many people. So now let's talk about the different causes of infertility in women. Age. So age is a key factor in a woman's ability to get pregnant. As women, when we get older, especially after age 35, the number and quality of our eggs go down. Endometriosis. So this is a common condition where tissue, similar to the lining inside the uterus, grow outside of it, which can cause problems with the ovaries, the fallopian tubes, and the uterus. Ovulation problem. So these are common and includes polycystic ovarian syndrome, which is a condition that affects hormones levels and ovulation, and thyroid problems. So issues with the thyroid gland can affect a woman's ability to ovulate. Problem with the fallopian tubes. So problem with the fallopian tubes can prevent the eggs from meeting the sperm. So this problem can be caused by previous infections, such as chlamydia gonorrhea infections, or endometriosis and surgery like tubal ligation. And finally, problem with the uterus. Problem with the uterus can also cause infertility, such as fibroids and polyps. So these are non-cancerous growth in the uterus that can prevent pregnancy. However, it's important to know that not all fibroid and polyps can cause infertility. Therefore, it is important to speak to your doctors. Uterine abnormalities. Abnormalities in the shape or the structure of the uterus can make it harder to get pregnant or carry a pregnancy. Scar tissue in the uterus, or known as adhesion, can also make it harder for a woman to get pregnant. So these factors can make it difficult for a woman to conceive, but there are many different treatments that are available that can help. And now let's look at the different causes of infertility in men. Hormone and health issue. So some men are born with hormone imbalance that affect their fertility. Drugs, whether it's for medical treatments or recreational use, can also impact a man's fertility. Serious illnesses or being overweight can also reduce a man's fertility. Problem with sperm production. So these can include genetic issues that affect sperm's development. Infection or exposure to harmful substances such as drugs, radiation, or toxins can also slow sperm counts and quality of the sperm. Problems with sperm movement. So some men are born with issues that affect how sperm move through the body. Vasectomy, a surgical procedure for men's sterilization, can be a cause if the man later wish to have children. And lastly, ejaculation issue, where sperm doesn't exit the body properly, can also be a problem. So one example is retrograde ejaculation, where sperms enter the bladder instead of exiting the body. So understanding this issue is important because it shows that men, just like women, may also need to undergo testing and treatments for infertility. Finally, so when should you get help for infertility? Here are some of the general guides. So if the female partner is under 35 and you haven't gotten pregnant after trying for 12 months, it is a good idea to see a doctor. If the female partner is over 35 and you haven't gotten pregnant after trying for 6 months, it is time to get some help. However, in some situations, it's best to get help even sooner. For example, if the female partner is more than 40 years old, if she has very irregular periods or no periods at all, if she has been diagnosed with severe endometriosis, if either partner has had chemotherapy or radiation therapy in the past, if you've had fertility issues previously with a different partner, or if there's a history of tubal ligation or vasectomy. Getting help early can be crucial in identifying and treating fertility issues and can increase your chance of a successful pregnancy.
Sorry, you'd think after all this time with COVID, I'd learned to take myself off mute, everyone. Thank you so much, Juan. That was very interesting. I'd like to introduce our next speaker now, who's our other co-medical director of public fertility care at the Royal Women's Hospital, Dr. Rashi Kalra. Thank you, Rashi.
Thanks, Katie. Thank you, everyone, for joining us tonight. Today, I'm going to talk about some basic tests for infertility that you might be familiar with and that you will undergo if you come through our service for treatment. So what to expect in the first appointment, like any other doctor's appointment, a fertility specialist will take a detailed medical history, both for yourself and for your partner. Things that we'll often cover in this medical history are, as Dr. Tay discussed, your age, the time that you've been trying to conceive, any prior pregnancies, your medical history, what we call a social history, which refers to things such as smoking, alcohol consumption, exercise, and whether you've had any major surgery in the past. We may or may not need to examine you, particularly if you report symptoms that could be very suggestive of endometriosis, or if you are the male partner in the relationship and you report, any significant testicular abnormalities. It is really important to institute effective investigations from the first appointment that you're seeing, and they are really important that they're done properly. Some tests are standard and other tests may be tailored to your individual circumstances or what you report when the fertility specialist takes your history. So I'll just talk you through the screening tests for the female partner coming through the service. Blood tests are essential. What we're looking for is we're screening for infections, hepatitis, HIV. These all have important implications in pregnancy. We're checking your immunity to rubella and chickenpox virus. We will check your blood count, your blood group, your vitamin status, looking at vitamin D and iron. We will check your hormones. And we may do a blood test called an AMH level if you haven't had one already. This is sort of colloquially called the egg timer test, but it is a test we'll talk about in a bit more detail in the next few slides that looks at your egg reserve. And we will also test chromosomes or carrier type for both yourself and a male partner. Genetic carrier screening is extremely important. It can either be done as a blood test or a saliva test, and that will be discussed. And we will do routine infection screening for sexually transmitted infections, such as chlamydia and gonorrhea being the most commonly seen ones in the community. And finally, a pap smear. It's extremely important for all women to have a routine pap smear every 5 years or more frequently if they've had a history of abnormalities. So the doctor will make sure that your pap smear is up to date, and a pelvic ultrasound will be organized at that point if you haven't had one already, looking at your uterus, looking if there's any factors in the uterus that may impact your ability to get pregnant. So in terms of the males, usually the initial tests are, again, blood tests, similar to the females. We look at your hormones, infection screening for hepatitis, HIV, and carrier type, as discussed for females. A sperm test will be requested at that point, and this is essential as an initial screening test. And we will also potentially discuss genetic carrier screening if it's indicated for the male at that appointment. So moving on to the next test, the pelvic ultrasound. I'm going to talk a little bit about this test because it is a very important test. So it's usually an internal ultrasound done by, ideally done by an ultrasound specialist that's also a gynecological expert. So somebody that is used to looking for reasons for infertility, looking for things such as endometriosis, fibroids, polycystic ovarian morphology of ovaries. So extremely useful test. Very important that it's done by an expert because it gives us lots of really valuable information about what might be going on from a reproductive perspective. The tubal patency test. At that point, the tubal patency test may or may not be ordered as well. So this is a test to check if your fallopian tubes are patent or to make sure they're not blocked. So as Dr. Tay discussed before, fallopian tubes play a very important role in fertility. Their job is to pick up an egg, and it's where the egg and the sperm meet and fertilization happens. So the tubal patency test is done under ultrasound guidance. A catheter or a plastic straw is passed into the uterus and it's flushed with some dye, and then we check that the dye flows out through the fallopian tubes, and that suggests that the tubes are open and they're not blocked. So the tubal patency test is one of the initial tests we may order as part of your workup if it's indicated. So this is coming back to the AMH test, the anti-Müllerian hormone test. It is a blood test. There is high variability even within women with the AMH level. So it's really important that patients are very carefully counseled about what this result means. We know that an AMH test done today may not be the same as an AMH test done 2 months later. It is, however, one of the better tests we have to reflect the number of eggs in a woman's ovaries. So it's purely a test of egg number. It's not a test of natural fertility. So a woman that has a low AMH will still ovulate 1 egg every month compared to a woman that has a moderate or high AMH. So it doesn't predict how fertile you are, how likely you are to get pregnant on a natural cycle. It just reflects how many eggs are in the ovaries, and then it also does help for IVF planning. It basically tells the IVF doctor what dosage of medication to give you in an IVF cycle to stimulate your ovaries to produce a healthy number of eggs. It is also important to know that low AMH does not predict the success rate of IVF. Being on the oral contraceptive pill can actually artificially reduce your AMH level. So, if a woman had an AMH tested on the pill and it was low, we would always generally try to get her to come off the pill and repeat it, without trying to create too much angst about a low AMH. So this graph here, if you have a look, so the bottom bar looks at age of the woman, and the vertical axis looks at the AMH level. And you can see that generally there is a subtle sort of decline in AMH or egg number that happens in a woman's ovary, starting sort of in her mid to late 20s and then progresses sort of more rapidly in her mid to late 30s. So what that suggests is that we know that egg reserve or egg numbers decline with time. But the important thing is, if you look at the blue dots, is that you can see, even, for example, if you look at a 27-year-old, you can see that the blue dots are spread all the way from the very bottom to the very top. And that just suggests that, healthy women can have a very wide range in their AMH level. A healthy 27-year-old could have an AMH anywhere between 5 to 20, and it doesn't necessarily predict fertility. So it's important for women to not get overly stressed about AMH. And given our clinics, women will always see a really highly qualified fertility specialist. They'll always receive proper counseling about the AMH level. So with reproductive genetic carrier screening, as of November, the government now rebates core carrier screening, which covers 3 genes: cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome. So these tests are now bulk billed for the woman trying to conceive, and if she's found to be a carrier of one of these genetic conditions, then the test is bulk billed for the male. So therefore, it's really important for patients to be given the option to have genetic carrier screening. It provides information about the chance of having children with an inherited condition. And we will find that up to 2% of couples could be affected by a gene that may have what we call an autosomal recessive pattern, which means that if a baby inherits an abnormal gene from each parent, it will be affected by a disease. The 3-gene test is what we call the core or the basic test. There are also expanded genetic tests available on the market, and we can test up to 1,000 genes really in a couple. And so it's really important that this discussion is had before couples move on to any kind of ART or IVF treatment. Coming to the semen analysis, so it's really important this is done at a proper laboratory that is used to looking at semen samples and commenting on them. The basic instructions for collection are generally for the male to abstain from intercourse for about 2 to 3 days prior to producing the sample, to avoid using lubrication to produce the sample, ideally, unless it's lubrication provided by the lab, or avoid using generic mainstream condoms to collect the sample in. We generally prefer the specimen is provided to the lab within about 45 minutes from collection, because we know that can otherwise impact the motility or the ability of the sperm to move and give a false abnormal result. And it's important for the specimen to be kept at body temperature. So we know that sperm, they don't like to be in extremes of temperature, so definitely don't keep the sample in the fridge before dropping it off to the lab. And finally, we never conclude that a male has infertility based on one semen analysis sample. We know that various factors can affect sperm number or motility, so things like a flu-like illness, a fever. And so we would always repeat an abnormal sample in 6 weeks to determine whether this is a chronic thing or a one-off.
Thank you so much, Rashi. I'd like to introduce you to our next speaker now, who is Head of our Reproductive Services Unit here at the Royal Women's Hospital, Associate Professor Kate Stern. Thank you, Kate.
Thanks so much, Katie. And thank you, everybody, for joining us tonight. We're so excited about public fertility care, and we really want to be able to make sure that our community understands what it is and knows how accessible it is. So this is a great honour for us to be here tonight to be talking with you. I'm going to talk a little bit about types of treatments that we have available. And I'm going to talk a little bit about this range of treatments: IVF, insemination, ovulation induction, fertility preservation, and general health lifestyle factors. So firstly, I would like to talk about the most important thing that we talk about with our patients when we first meet them, and that's about lifestyle modification. Can I have the next slide, please? The next slide, thanks. So everybody has the capacity to optimize their general health and well-being, and we're not obsessive about it, but everything in moderation is our motto. So it's important to be in a normal-ish weight range, you know, not obsessively within your BMI, but to do your best. Healthy eating is important, and healthy eating is not some wacky diet that you've read about or something that will make your eggs better or your uterus better or your periods better. Healthy eating is general healthy eating. There's no magic in it. Now, regular exercise is also important, and we say 30 to 40 minutes at least 3 or 4 times a week. And I must stress actually that regular exercise is very good for our mental health as well as our physical health and our fertility health. So we really mean it when we say doing something at least 3 to 4 times a week. Ideally, we'd like people to be exercising for 30 to 40 minutes. And this can be a mixture of aerobic exercise or resistance exercise, going for a walk, Pilates, a whole range of things. You can do online programs, whatever. Equally important is being able to relax. For lots of people, there is considerable concern about being busy and about being stressed and the impact that will have on your fertility. And it's fine to have a busy job and everybody gets stressed, but what we want to be able to do is to be able to switch off, not feel guilty about that stress, but have some strategies for mindfulness and relaxation. I mean these things very, very seriously. They're very important parts of fertility management, parts that we can all have control over. So clearly, we really don't want people to smoke or vape. There is evidence that smoking and an increasing body of evidence about vaping can have a bad effect. Smoking can actually reduce the age of your, the health of your eggs such that you can go through menopause up to 2 years earlier. So that's quite important. Coffee, ideally not too much. 1 or 2 coffees a day is fine. You know, there's quite a lot out there about no coffee, no this, no that. There is no good evidence that having 0 coffee is substantially better for you than having 1 or 2 if you're someone that likes coffee. And it's a bit similar with alcohol, actually. The evidence is that more than 8 drinks a week can be associated with slight impairment of fertility optimization, but there is good evidence that less than that is fine. Ideally, we say none because it's just easier to preach none rather than moderation. But if you want to have a couple of drinks a week, that's okay. We don't want you having 10 drinks all at the one time. So ideally, no alcohol, but there's no need to angst about having 1 or 2 a week. And as I said before, stress. I know it sounds ridiculous, doesn't it? But I'm saying don't stress about being stressed. It's okay to be busy and be stressed, but what you have to do is make sure that you can come home, relax, and do some exercise and not worry about the impact this is having on your fertility. Thanks. Now, the next treatment I want to talk about is called ovulation induction. And that is exactly what it sounds. In women who don't ovulate regularly, and by that I mean within sort of 26 to 35 or 36 days. Some people will have a 28-day cycle and then a 50-day cycle and then an 80-day cycle. And it's terrible stress when you're trying to conceive, working out when you're ovulating. So we use tablets or injections depending on the cause of the irregular cycles to help regulate ovulation. And if it's tablets, we have a course of 5 or 6 tablets, and then we do ultrasounds. And you can see on this lovely picture, I love looking at pictures of the ovary. This is a beautiful big follicle that's going to ovulate, and there are 3 little ones as well. So this is tablets or injections depending on the cause of your infertility. Polycystic ovarian syndrome can cause irregular cycles. High levels of prolactin can cause that. Being underweight or very overweight. There are lots of different causes. Next slide, thanks. The next treatment is something you might have heard about called IUI, or AI, but not artificial intelligence, artificial insemination. And it's called intrauterine insemination. And that's a treatment that we use mainly for youngish women who don't have protracted infertility, who haven't got very severe infertility, who have normal tubes and their partner has normal sperm, but they're just having difficulties getting pregnant. We also use it for donor insemination for single or same-sex couples when we need to use donor sperm. And we usually couple it with low-dose injection. Sorry, we'll need to go back a slide, please. We couple it with low-dose injections to give the hormones a bit of a boost. And we have some semen which gets washed in the lab. And here's a lovely picture of the semen, of the sperm, all going in the right direction, which is great. And we wash the sperm and we put it in a little tube. And we just put that tiny little tube through the cervix. So that's called IUI, or artificial insemination. It doesn't hurt. You don't need an anesthetic. And that's a treatment that we use early on for unexplained infertility or for our patients who need donor sperm. Thanks. Now I just want to briefly talk about the IVF process. And when we say IVF, that's in vitro fertilization. We're talking about the sort of overall process. I'm going to go into a tiny bit of detail, but just in essence, what that involves is initially stimulating the ovaries with some injections to get quite a few eggs at one time, and then retrieving the eggs and putting the eggs and the sperm together. And then we grow the embryo in the laboratory for 5 days, and we can watch it grow. It's quite amazing. And then on day 5, if we're going to go ahead with a transfer, we take a little embryo and we pop it inside. And it's a bit similar to what I showed you just before for the insemination. That doesn't hurt, no big deal. And we put it inside the uterus. It then moves around a bit despite how carefully we put it in there. Now, if we've got extra embryos, we can freeze those. And then we give some extra hormones and do a pregnancy test after a nervous wait for about 10 days. Next slide, thanks. So I wanted to show you, firstly, what happens when we stimulate the ovaries. So we use FSH injections, which are the same as the hormones in the brain acting on the ovary. And we do ultrasounds. And you can see in the slide on the left, there's one follicle. And in the slide on the right, that's showing you quite a few follicles. And that's what we're trying to do, because we're keen to get more than one egg at a time. And we do this with close supervision with ultrasound monitoring as we go. The injections are actually surprisingly easy. Everybody says, oh my God, I can't do it. And then most people usually manage to do it. And this is just a little illustration. It's a bit complicated, that just shows you have your injections for 10 to 14 days, and you have a second injection, one that stops those follicles ovulating for the last few days. And then we do the procedure to take the eggs and put the eggs and the sperm together. And then we'll do the transfer 5 days later. Now, when we take the eggs, that's done in the operating theatre. It's actually under sedation, not a huge general anaesthetic. It's very, very light, but you're actually asleep. So it's not a general, it's sedation, but you are completely asleep. And so you just wake up at the end of the procedure. And we put a little tube, the vaginal ultrasound probe with a little needle through the vagina. So there's no cuts or anything on your tummy, and we can access the ovaries that way. on here's a slide of our lovely scientific director, Michael. So the lab is where all the magic happens, let me tell you. So in the lab, Michael's team and in other services, the scientists will get the eggs and then they'll put the eggs and the sperm together. And you can see day one, that's a day one embryo. And you can see the two pronuclei, the eggs from the egg and the sperm. And have a look at day 3. It's starting to get bigger. You can see 7 or 8 cells there. And then on day 5, we get a lovely blastocyst. And sometimes they even start to hatch out of the eggshell. So it's very cool. And we do our transfers on the whole on day 5, and hopefully we have a lovely blastocyst there. The transfer is very similar to the artificial insemination. It's done with no anesthetic. It's just like really having a pap smear. And it takes about 15 minutes. And we use an ultrasound to help position where we put the embryo. And then, as I said, we do all that hard work, and then the embryo will float around for another day or two before it makes its implantation in the wall of the uterus. And then we wait for the pregnancy test. Now, there's really no point doing blood tests or urine tests earlier. We do the test at 10 days after we've done the procedure, which is 2 weeks after the egg was taken or you've ovulated. Now, this is just a little beautiful video which shows an embryo developing. So you can see here it's splitting into cells. This is taken over the 5 days. It's just magic. So now it's getting its own identity, taking on its own genetics, and it's made a beautiful blastocyst. I hope you love that video as much as we love. Now, success rates. This is a controversial topic. You know, you can read about this stuff in so many different places, and, you know, often we're not comparing apples with apples. But I guess the message I want to get across is mainly that fertility treatment is very successful, but it often takes a couple of cycles. So if you're under 38, you've got over a 50% chance of having a baby, actually having a baby from 2 cycles. And in public fertility, we're allowed to do 2 cycles. So you've got at least a 50% chance of getting pregnant. And that is using the embryos as well. I guess the second message is that with time, fertility diminishes. IVF fertility diminishes just like spontaneous fertility. Now, in terms of risks, it's not a procedure that's without risk, but the risks are very well controlled and managed. When you have your fertility treatment in a specialist centre, everyone's really geared up to understanding the process and knowing how to avoid and reduce and manage the risk, because occasionally stuff happens. It's very common to get bloating, and there's a very small risk of a condition called hyperstimulation when you have lots and lots of eggs. And we have medicines now that really control that for most patients. The risk of an infection inside the tummy after the treatment is about 1 in 8,000. And that is much more like, it is 1 in 8,000, mainly in people that have had previous pelvic infections and stuff. There is a small risk of clots in the legs, what's called a DVT, and that's from the hormones. The risk is about the same as when you're on the oral contraceptive pill. It's emotionally tough, and we need to call that out. And we can maintain our optimism for having success, but still have to ride those waves every month. And it's really important. I can see I'm clenching my fist here as I say it. It's really important to understand that this treatment often takes a while. It is not a one-hit wonder. So you have to hold your nerve just like your treating team. And your treating team will advise you about how it's going and what our chance of success is.
Thank you so much, Kate. That was wonderful. Thank you for sharing. Now I'm going to talk to you about public fertility care, the cost, eligibility, and the waiting times. So what is public fertility care? So public fertility care is a Victorian government-funded fertility service available to all Victorians. It aims to make fertility treatment fairer and more affordable for Victorians, particularly those with limited access to existing private services. It's a free service. However, some patients may have a small amount of out-of-pocket costs for some medications, diagnostics, or specialist tests. So the Women's partners with 10 other hospitals in Victoria, so your care can be managed close to home. So all referrals are sent centrally to the Women's. We'll then forward your referral to your closest partner site where an appointment will be scheduled. The structure of public fertility care is to enable people to have as much care as possible close to home and only require you to travel to the Royal Women's Hospital for your procedures such as egg collections and embryo transfers, as Kate mentioned in her presentation. So the exact range of services available at each partner site will differ slightly depending on the site, but patients will be supported by telehealth where appropriate. So Juliana will talk a little bit more later on about a patient journey. So how can public fertility care help? So all eligible Victorians who want to start or grow their family, whose health may prevent fertility, people that have been trying to conceive naturally that have been unsuccessful. So this includes people who may have already have children, single people, and people within the LGBTIQ+ community. So let's talk about the eligibility criteria. So public fertility care assists Victorians who have been unable to conceive or whose circumstances may prevent them or impair their fertility or safe conception. So they need to be a Victorian resident with a Medicare card. You need to have a referral from a GP or specialist, which includes the necessary tests and investigations. And our list of these can be found at our website. And I just want to point out here that public fertility care is not means tested. So let's talk about the age criteria. To access public fertility care, you need to have commenced your treatment cycle before your 43rd birthday if you're using your own eggs. If you're using an egg donor, the donor needs to have commenced their treatment cycle before their 43rd birthday. So if you are 43 or over, there are still options available. You can access public fertility care with the use of donor eggs up until your 51st birthday. So public fertility care offers a full range of fertility services, which you can see listed here. So Kate talked to us about IVF and ICSI, which is ICSI is just a different way of fertilising the eggs. She talked to us about intrauterine insemination, ovulation induction. We offer medical fertility preservation. So for patients that may be undergoing cancer treatment or gender affirming care, we offer fertility counselling, donor services, genetic testing, and we'll be shortly launching our altruistic surrogacy service. We do not, however, offer reversal of sterilisation or elective egg freezing. Now, public fertility care has a lifetime limit of 2 stimulated IVF or ICSI cycles per individual, but this does include all frozen embryo transfers that are created from those 2 stimulated cycles. So how do you access public fertility care? So please go and talk to your GP or your specialist. They'll ask you to complete some blood tests and other investigations such as ultrasound scans and semen analysis that Rashi talked to us about in her section. Your GP or specialist will then send the results with your referral to the Royal Women's Hospital. The current wait time for a first appointment is approximately 4 to 8 weeks. Now, this will depend on which partner site you're attending. So I'll talk to you now about egg and sperm donor programs. So Australia's first public egg and sperm bank opened at the Royal Women's Hospital in July of last year. We are currently accepting egg and sperm donations from the Victorian community. The current wait time for recipients to access clinic-recruited eggs and sperm is approximately 18 months to 2 years. However, we can also facilitate known donor relationships. So if you have someone that is able or willing to donate eggs or sperm to you, we can facilitate that relationship for you as well. I'd also like to point out that access to the donor program is also at no cost. That is all from me for now, and I'd like to introduce to you our Nurse Unit Manager, Juliana Cosmo, who's going to take you through some patient journeys. Thank you, Juliana.
Thank you, Katie, for introducing me, and hello, everyone. So I'm going to be walking you through 2 patient journeys today. The first example I have for you here is a heterosexual couple. Both of them have eggs and sperm of their own that they are able to use, and they've been trying to have a baby for the past 12 months and haven't been successful. So what they would need to do is go to their GP, talk about their experience. The GP can order some tests, and some of these tests may have an out-of-pocket expense, and then refer you through to our public fertility care service. Now, the Royal Women's Hospital will be the team that receive your referral, and when they receive your referral and accept it with all the required screening tests from the GP, we will send you an acceptance letter. So you will receive that and know that you've been accepted by the program. We will then send your referral to your local fertility care provider, so public fertility care provider, and Katie showed you a map of where those are located across the state. You then have roughly a 4 to 8 week wait for your first appointment with one of our doctors and specialists. And you will receive a letter from those providers letting you know when that first appointment will be. Typically, we like our first appointment to be face-to-face if appropriate, but on the occasion, we know that if you're in a regional area and it's difficult for you to travel, we can also facilitate those appointments via telehealth. Now, at these appointments, our clinical team will review test results. They may also decide to order additional tests. They will talk to you about different treatment options. And then if they decide you need to proceed with fertility treatment, they'll discuss and sign consents with you. On average, a patient will probably have 2 appointments with a fertility specialist within the public fertility care service before they proceed on to the next stages of their care plan. So what normally happens next is that they will have an appointment with a wonderful nurse who will talk through your treatment plan with you, provide a bit of education about the treatment plan and how it will affect your body, interact with your body, and what the different stages of the treatment plan are for you. They'll show you all your medications and how to use them, and they'll show you how to contact the clinic and at what points you'll be in contact with the clinic. After your nursing education session, you will then have a counselling session. Now, the counselling session is a Victorian legislative requirement. And in these sessions, they normally do a well-being check with you, and they discuss different possibilities of treatment outcome, what it might mean for you to have biological material in storage, and help you address any other questions and concerns you might have about going through the treatment. With the counsellors, you will also need to sign a consent to proceed. After you've completed counselling, you're normally ready to commence treatment. If you're unsure, our lovely nursing team will always be able to answer your questions and you can reach out to them and ask any questions that you might have before starting treatment. Typically, from your first appointment with the clinician to being able to start with treatment, it varies on how long that will take, depending on your medical history and the amount of clinical workup that's required. Now, once you've started your treatment, your nurses will walk you through what you need to do, including medications and ultrasounds and different tests. And when you're ready to have your eggs collected, they will provide you with a date, and your egg collection happens at the Royal Women's Hospital. So all procedures happen at the Royal Women's Hospital. Our lab is located here, so all those beautiful pictures that Kate Stern showed you, all that magic happens in our labs over here at the Women's. And then once you've got a blastocyst embryo that is ready to transfer, that also will happen here at the Royal Women's Hospital, and that typically happens 5 days after your egg collection. You'll be provided ongoing support and care from the nursing team. And in regards to pregnancy follow-up, we will hope to see a positive result for you. And if we do, we manage pregnancy up to 7 weeks, and then we discharge you back to your GP for ongoing obstetric care. If you have not received a positive result, our clinical team will spend some time with you discussing other options available to you for treatment. So our second example are patients that are seeking treatment, but they don't have an egg or sperm that they have access to. So they're seeking an egg and sperm donor, and this could be a single person seeking treatment, a same-sex couple seeking treatment, or a heterosexual couple seeking treatment where one of them don't have gametes of their own to provide. And what they do again is they go to a GP and request a referral to the service. In this case, they don't have to usually prove any infertility, so they don't need to wait 12 months. There's no chance of them getting pregnant if they don't have those eggs or sperm available to them. And the GP will do those series of tests. As I mentioned earlier, there is a possible out-of-pocket cost with those tests, and we will receive that referral, and you will get a letter in the post acknowledging that the referral has been accepted. You will go through the same discussions with the fertility specialists, but there's something a little different to this one, is about how we're planning to get that egg or sperm. So you have true treatment options, and this was discussed with Katie. You can use a clinic recruited donor, which is a donor that we've recruited ourselves at the Royal Women's Hospital, and that donor will be de-identified to you. Or you can bring along someone whom you know that might be willing to donate to you. And our clinical team will connect you up with our lovely donor team, who will be able to provide you all the information required for your journey with a donor. Now, if you're using a clinic recruited donor, the wait list at present is roughly 18 to 24 months. Your donor team will be able to update you on the most current wait time when you speak to them. Now, you will then have a nursing education session, and that is the same as the other session, essentially talking you through treatment, different stages of treatment, how you stay in contact with the clinic, the different support you will receive, what medications you might need, everything like that, and we will help address any questions that you might have at that time. For donor patient-seeking donors, mandatory counselling is compulsory and a legislative requirement for you as well. And the government does require a minimum of 2 counselling sessions for both the person who is donating and for the person who is receiving the donation. And again, in these sessions, it will be a general well-being check. It will be talking to you about what it means for you to conceive a child using donated material. And there's a lot of things, other things that they may discuss with you at that time. There will be a counselling consent, like the medical consent, that you will need to sign before proceeding with treatment. When you're all ready, again, you're reaching out to the nurses. The nurses will be able to tell you what else you might need in preparation to commence treatment. But normally at that stage, everything should be done, and it's just about calling through to the clinic at the time advised to start your cycle. And then everything runs pretty much the same for both the heterosexual couple and the person seeking egg donor. You will, egg or sperm donor, my apologies. You will undergo medication and treatments, scans and potentially blood tests. and those scans are ultrasound scans, as described by Kate earlier on. Your egg collection will happen at the Royal Women's Hospital. Our fabulous labs will be working hard in the background, and the embryo transfer will occur 5 days after the egg collection. In the same way, we will provide you ongoing support and care after the embryo transfer. If you have been successful with pregnancy, we will manage you up to those 7 weeks and then discharge you back to your GP. If you aren't, then the clinical team here will discuss what other options are available to you. And that is the example of 2 journeys there.
Thank you,
Katie.
Juliana. That was wonderful. Thanks so much. Now we have a few questions that we've gathered together that were submitted when you registered for the session. So thank you so much. I've just pulled the team back together and we're going to run through those questions now. So a common question was about, is it income or asset tested? So I'm happy to answer that one, and the short answer is no, it is not. So I'll just reiterate, 2 stimulated IVF or ICSI cycles at no charge, and the service is not income tested. The next question, so being 44, is egg donor my only option? Kate, would you like to take that one?
Thank you. So yes, it's a tough question because unfortunately for many people that we see, life hasn't gone their way and they find themselves in their early 40s wanting to get pregnant. Now, the harsh reality is that at 44, it's very difficult to get pregnant, but not impossible with your own eggs. Now, in our program, we can only try stimulation for someone before her 43rd birthday. And that's one of the mandated criteria for our program. So if you were 44 and you had had an assessment with your outside doctor and you had very good ovarian function for your age and you seem to have quite a lot of eggs for your age, then you still do have a choice to try treatment with your own eggs. But unfortunately, we couldn't do it in our program, but you could go to other places. Now, just to set the scene, at 44, if you get an embryo, so you've jumped through all the hoops and had the stimulation and got the sperm and made embryos and got an embryo, so you've done pretty well to get there, then, and we put that embryo in, the chance of that embryo making a clinical pregnancy is 3% or less. And the miscarriage risk is about 35 to 40%. So with your own eggs at 44, the chances are not always impossible, but they're very low. But just to reiterate, we cannot, unfortunately, help women with their own eggs over the age once they get to 43 in our program, but you could go elsewhere. However, we can offer egg donation. And as has been discussed already, there is unfortunately quite a long waiting list at the moment, unless you have somebody that can be a donor for you. If you have someone that can be a donor for you, we can accept you into our program and instigate treatment once all the relevant counselling has been performed. There's no undue delay. But if you're waiting for a donor in our program, the waiting list is very long, and I have to say it's unpredictable. Just as a call out, we're really, really also open to have discussion to any women who think that they would like to do something amazing and donate their eggs, because we're always in need of that generosity from women who want to be able to give. This is truly giving the gift of life, much more than blood, I say. And so we really want to be able to have women that are interested in freezing their eggs and helping other women to have a family. So, but at the moment, our waiting list is over 18 months. And we know that women also look elsewhere at other programs trying to find egg donors. Sorry, Katie, a bit of a long-winded response, but just wanted to, also put in my plug for people to consider being egg donors.
No, that was great. Thank you, Kate. And sperm donors too, if there's anyone out there.
And sperm donors,
yeah.
Exactly. Give me another high horse.
Yeah. Thanks, Kate. So the next question they ask, I've been going through IVF in the private sector and simply cannot afford any more rounds. We have viable embryos stored. Can we transfer them if we go through the public system to continue with IVF? Juan, do you want to take that one?
Yeah, thank you, Katie. The short answer for this question is yes. The long answer is you do need to meet the criteria for public fertility. So if you have frozen embryos from another fertility center, you can bring the embryos to us as long as you are a Victorian resident, you have Medicare, and these embryos have been created using eggs less than 43 years old. If you fulfill all these criteria, by all means, you can bring them to us and we can transfer them for you. And these will not be counted as your 2 stimulated cycle. So in the event, if we are unsuccessful, unfortunately, with this embryo, we use them up, you still haven't gotten pregnant, you still can go through your 2 cycles of egg collections with public fertility. Hope that makes sense.
Great, thank you, Juan. And the next question says, can you discuss the process for regional couples? So an example that this person gave was that Shepparton now has a hub, but does this mean the procedure takes place with Goulburn Valley, or will the couples go to Melbourne? Juliana, I feel like this is a question for you.
Yeah, I can answer this one. So in regards to some of our regional centres, you will be able to have your blood tests locally, your ultrasound scans locally, your medication teach locally. So most of your cycle management will happen locally, but we have the lab here at the Royal Women's Hospital in Melbourne. So for your egg collection, you will need to travel to the Women's Hospital in Melbourne to have your egg collection procedure. And you will need to travel to the Women's Hospital to have embryo transfer procedures or intrauterine insemination procedures. So anything that you're doing that means we're taking egg or sperm out of the body and using it will have to happen here in Melbourne. Everything else we will be able to manage locally for you.
Fabulous. Thank you so much, Juliana. Now, to check that we've managed to answer all your questions, we, I believe, are going to put a survey in the chat. I'm hoping it should be live in the chat. So if you wouldn't mind taking the time to fill that out, we would really appreciate it. And then we'll also be sending you a link to the survey and also provide access to a recording of this session, probably within the next 24 hours. So please look out for that. But I really just want to thank everybody so much for attending this session. We hope you found it informative. And I want to thank all the speakers for attending and sharing their wonderful knowledge with you all as well. So thanks again for attending our session on public fertility care. We hope we have helped to answer some of your questions and we hope to see you soon. Thank you, everybody.